Hi, everyone. This is E. David Crawford, Editor-in-Chief, Grand Rounds in Urology. Joining me to discuss the ongoing challenges facing urology practice with this COVID-19 is Dr. Leonard G. Gomella. Lenny is Chairman of the Department of Urology at the Sidney Kimmel Medical College. He serves on a lot of committees and has contributed significantly to urological education. He's also editor-in-chief of the Canadian Journal of Urology. So, Lenny, thanks for joining us, and tell us how you in an academic center are dealing with all these stresses that are occurring right now.
Well, thanks, Dave, for this opportunity to sort of discuss what we're doing, and I look forward to learning what others may be doing. So, a few things about working in an academic medical center. A lot of what we do is determined by our leadership. So we actually have a command center set up here at Jefferson, and we have 2 phone calls a day. We have a 10 o'clock phone call with all of our colleagues across the Jefferson Health enterprise. And then at 1:30, we have a more specific phone call with just the chairs and the service line directors to address operational issues. So being the part of a large academic medical center, a lot of our decisions and how we approach things is sort of organized at a higher level of leadership. Having said that, there are some good things for us being in an academic medical center. One of them is the fact that we have a very significant financial backstop. And what do I mean by that? Well, I know that I'm seeing on emails and other news feeds about a lot of private practices having to lay off not only staff, but not being able to pay their providers, which is very concerning if I was in private practice. Most of what I've seen on my news feeds have been in orthopedic practices, but one of the benefits of being in an academic medical center, at least at this point, the providers and the faculty members are not at risk of losing any salary. Now, having said that, many of my junior faculty are very worried about RVUs, and we're trying to get everybody to step back and say, ladies and gentlemen, this is not the time to worry about your RVUs. This is the time to worry about for us caring for our patients. So what we've noted in our department is the fact that we have certain colleagues, and I'm calling it an asymmetric practice model right now. We have gone through a tiering, which I will talk about in a couple of minutes, where from an institutional standpoint, we've had to identify cases that can wait and cases that have to be done. And they go to an OR committee, and we get approval for them most of the time, unless they're really something that's truly elective. But what that's done is created, again, what I call an asymmetric practice model in our department, whereas those that are doing things like infected stones or patients with stent management, patients with bad cancers are able to go to the operating room, whereas others, which are not as a priority, a symptomatic BPH patient, somebody who needs circumcision or has some benign scrotal pathology, the general urologists are not able to get to the OR as much. So I'm worried about, as the year goes on, that asymmetric model and how that may impact RVUs. But at the end of the day, our messaging to our faculty is, hey guys, this is an unprecedented crisis. We're not going to worry about RVUs right now. We're not going to worry about, who's earning what. We're just going to be worrying about caring for our patients. And in that regard, I will say that Thomas Jefferson University has been far ahead of the curve in telemedicine and telehealth. So we have been actively engaged in telehealth for over 3 years now. And we have actually gotten some awards in our department from the institution for how proactive our faculty have been over the years. So right now it's been a very natural transition from us going from face-to-face urology office visits and transitioning to telemedicine. So right now, probably between a third to a half of our outpatient visits are actually being conducted by telehealth and telemedicine. And again, we have a very robust platform that Thomas Jefferson University has set up for us. Having said that, we still do have some patients that want to come in. Our normal outpatient volume in one of our biggest offices is around 170 to 200 patients a day. Over the last couple of days, that's been running about a total of 50 patients coming in. But of that 50, when I say 50 patients coming in, about 30 of them are physical visits and about 20 of them or so are telehealth visits. Now, for all the wonders of telehealth, we do have a problem that some of our more senior patients and others who may not be as tech savvy are unable to do telehealth. So we do have permission from our Jefferson University leadership to do phone visits with patients. Many of you may be aware of the fact in your local area, the cross-state licensing issues have been temporarily suspended between Philadelphia, New Jersey, and Delaware. So in fact, we are able to attend to patients across state lines. Normally, if you didn't have a license in New Jersey, let's say, and you were working in Philadelphia and you had a patient in New Jersey, if you had a New Jersey license, you could do a telehealth. But if you didn't have a New Jersey license, you couldn't do a telehealth. We're very pleased that the leaders of the 3 states have abolished state licensing requirements for the present time, so it allows us flexibility to care for our patients across state lines. As of this morning, on my big conference, we have been told that there may be a total suspension of the cases unless they're true life-threatening emergencies, and we have classified in our leadership group things like obstructed kidney with infection, abscesses, infected prosthesis, Fournier's gangrene, testicular torsion, penile fractures, priapisms, gross hematuria with clot retention. We've had to give the absolute must-do cases to our leadership. But even some of the cancer cases right now, even orchiectomy for suspected testicular cancer may have to wait a week or two. So we're certainly in crisis here in Philadelphia, but nothing to the degree that our neighbors to the north are going through right now.
Lenny, that was an outstanding overview of the many challenges that we're facing and how you're dealing with them. I'm impressed. I sort of think that, sort of a blessing in disguise with this COVID-19 or some of the things that are happening. We're learning with triage and more importantly with telemedicine. I think it's opening the door, and I hope some of these barriers are broken down, the interstate barriers, to make it happen. Yes, I think that really is the wave of the future. So thanks for sharing that. Anything else you want to add? And we'll stay in touch as we go through this. Anything else before we sign off?
I want to thank you for this format. I look forward to how others are dealing with it. And as we recognize, as urologists, we're certainly not on the front line of this crisis, but we all have to be aware of the fact that, number one, there are patients who still do need our care for important urology issues. And the other thing we have to remember is that at any point in time, we as urologists may be conscripted to start to function in other areas of healthcare, provided the situation, if the situation gets worse. We have to be aware that we may be working in other frontline situations such as the ER or possibly on inpatient services. So I hope everybody stays well and keep our fingers crossed we nip this thing in the bud, and that the long-term consequences and the long-term duration may not be as grave as a lot of people feel it may be.
Great. Lenny, thanks a lot for your time. We appreciate it.